quite an honor to be able to talk amongst this group of people. My background, first off, the Department of Defense disclaimer, these opinions represent my opinions only and do not necessarily represent the opinions of the United States Army, Department of Defense, or my place of employment, the Army Institute of Surgical Research. A little bit of a qualifier. So I've had 6 deployments to Iraq, Afghanistan, Syria, in various roles as a trauma surgeon, and have been involved with development and training of personnel on the use of walking blood bank in various levels of austerity. So this is a very interesting subject that's gone through quite a lot of evolution in the U.S. military over the last 20 years. And I believe to have an educated discussion about this, it's important to talk about the history. So to go back to the beginning, the first human-to-human blood transfusion occurred in 1818. In combat, the first reliable transfusion of patients occurred during World War I. And this was a surgeon from Canada named Bruce Robertson, who brought a technique back from a hospital in New York. This initially, blood transfusion fell under the purview of the surgeon because it required a venous cut down and collection of blood in glass tubes, and then directly carrying the tube of whole blood from the donor to the patient, as you can see here in the bottom figure. And I bring that up just to say that in my experience, when I started my training, transfusion science for trauma was not in the hands of the surgeon, but in the hands of the pathologist. And I think one thing that we've learned is getting it back into the hands of the surgeons as far as the experience, because it's important when talking about transfusion for trauma patients that you know where we came from, and you can, in an educated way, request what's needed for your trauma patients. He directly transfused from co-located minimally wounded casualties, warm, fresh, whole blood into severely injured patients. And he did this without cross-matching patients, and 62% of these patients lived. There was another surgeon, last name Robertson, no relationship, that during World War I as well, he collected and cold stored type-specific whole blood and transfused that at casualty clearing stations in a distance away from the front lines. So I mentioned that to say that from this experience in 1917 and 18 in World War I, there's been about 100 years of evolution that's brought transfusion science for trauma in a full circle, away from and then back to the use of whole blood in trauma transfusion or trauma resuscitation. And these advances look like a lot of the following. We were able to successfully and rapidly cross-match to know blood types of patients. We developed the ability to test for transfusion transmissible diseases such as malaria, syphilis, and then more recent times, viral hepatitis and HIV. We developed safe anticoagulants to prevent fibrillation of the blood. We developed the ability to refrigerate and store the blood. We developed the ability to transport blood over long distances. And then ultimately we were able to, and I say we, I mean the medical community as a whole around the world, able to separate blood into its various components. So blood banking science became quite complex. And these advances as well, we developed the ability to collect and store blood in plastic as opposed to large glass containers that are much easier to store. And the US experience, all these advancements were taken into the various theaters we've been involved with, from World War I to the Korean War and Vietnam. And I mentioned those. I'm going to take a brief hiatus in discussion of transfusion to talk about how that circle kind of went around away from the use of whole blood. So this paper is from Dallas in the 1960s, and this group looked at isotope tracing to look at the various components or compartments in the body. And this is where the term third space. So their first space was intravascular, their second space and third space. Third space was the interstitial compartment And they studied dogs, and they looked at dogs that had sustained in a lab hemorrhagic shock, and looked at the various compartments and looked at what was deficient in these animal models, and found that this third space, this extravascular interstitial space, was significantly lacking in extracellular volume. And in a 30-dog study, they determined that dogs that received whole blood and received the adjunct of lactated ringers, so isotonic crystalloid, they had a better mortality than the dogs that did not receive whole blood. There was a plasma group that led to the recommendation that isotonic crystalloid in the form of lactated ringers be used as an adjunct to whole blood for trauma resuscitation. I mention that because for the next 30 plus years, these studies were misinterpreted, and our trauma resuscitation practice was based on misinterpretation of this data. Modern blood banking technology that involved component therapy for things from cancers to medically induced leukopenia, thrombocytopenia, and trauma resuscitation, and very little scientific evidence about appropriate transfusion in trauma patients. So we had 30 years and misinterpretation of data that led to where our trauma resuscitation practice was at the beginning of the wars in Afghanistan and Iraq, which is 2001 to essentially present day, unfortunately. This is just a picture that shows an example of what this type of transfusion looks like. So this misinterpretation of Shire's paper that talked about lactated ringers as an adjunct, we have crystalloid-based initiation of trauma resuscitation. So we talk about 2 large bore IVs and lactated ringers. Components were then used in quantities that were not consistent with the blood bleeding out on the floor. So you would 2 to 4 liters of crystalloid were given, followed by packed red blood cells, and after 4 to 6 units of packed red cells, thawed plasma that was cold was transfused, and eventually you got to where platelets were given, and then eventually cryoprecipitate. So this is a trauma patient who received 20 plus liters of LR, 13 units of packed red cells, 14 units of fresh frozen plasma, and then 2 units of platelets. And this is massive bowel edema in a patient who's not going to be able to have these contents returned to the abdomen for a very long time. They'll have loss of domain, a planned ventral hernia. And these are some of the complications of that type of trauma resuscitation we saw into the 1990s and early 2000s. So just to summarize where we were when we get to the point where I enter the medical world, we have a crystalloid predominant trauma resuscitation. We have component-based transfusion in unbalanced ratios based on really no science. So there's no science that says that this transfusion practice is good in trauma patients. A few positives is we do understand that in penetrating torso trauma, hypotensive resuscitation is beneficial. That means if resuscitation is needed, you use endpoints like mentation or a lower systolic blood pressure than normal. Damage control surgery has become embraced by the trauma community. And then we are understanding some of the physiologic sequelae of hemorrhage, such as the lethal triad we talk about: hypothermia, acidosis, and coagulopathy. So now we enter the conflicts in Afghanistan and Iraq, and we see, as was mentioned earlier, these mass casualty events where we have limited resources. We have catastrophically injured, and that term begins to be used. Catastrophically injured casualties, where we have 2 and 3 and sometimes 4 limb amputees with penetrating torso trauma, head injuries that have exsanguinating hemorrhage that do not survive with that typical type of resuscitation, or if they do, it's rare. This term begins to be used. So we talked about briefly damage control surgery. There's also a term that evolved called damage control resuscitation. Some people use the term hemostatic resuscitation. And early in the wars in Iraq, what was noticed was that when blood components were transfused in a ratio more consistent with what is coming out of the patient, patients tended to do better, at least in a retrospective study. So this led to the transfusion of blood components in trauma and a 1-to-1-to-1 ratio when you look at packed red blood cells, plasma, and platelets. So a 1-to-1 ratio began to be more widely accepted. In addition, out of necessity, whole blood was being used, and these were walking blood banks that had been developed out of necessity. Again, our blood banks were limited either in the number of components, or some places did not even have platelets available. And walking blood banks were used, and warm, fresh whole blood was collected and transfused. And in retrospective studies, there seemed to be benefits as well. So I'm skipping around just a little bit in my talk. We mentioned earlier damage control resuscitation and some of the physiologic problems we talked about. In addition, we see hypocalcemia, we see hyperfibrinolysis, and this damage control approach includes blood products, but it also includes some non-transfusion practices such as tourniquet application, damage control surgery, stopping junctional hemorrhage, antifibrinolytics based on the CRASH-2 study, the use of tranexamic acid, and transfusions of products either in a 1-to-1-to-1 ratio or whole blood. To review everything that happened with transfusion science during Afghanistan and Iraq would take quite a long time. But in brief, we get to the place where we're using transfusion of 1-to-1-to-1 ratio blood products, so more consistent with what's coming out of the patient, followed by whole blood. Then we're able to push blood products out further than just the sites of patient triage and surgical care. So we have blood components such as red blood cells and plasma on the helicopter evacuation platforms. Then we are able to put, we call them golden hour bags, so coolers on the back of our combat medics, and they carry red blood cells and plasma. Then as we have more experience with the use of whole blood, we develop the Tactical Combat Casualty Care Consortium pushes out the guidelines that the recommended transfusion product of choice for pre-hospital care is whole blood. We then, some of our more advanced combat units, such as the Ranger battalions, develop the ability to do point of care walking blood bank, so they can get warm, fresh whole blood from members of that casualties team. And the way they go about this is prior to deployment, they will screen all the members of that unit. They will identify the type O donors, potential donors, and then they will check for the anti-A and anti-B antibody titers. And they will identify low titer O, and those patients will be basically a walking blood bank that's co-located with potential casualties, so that if someone's injured, they show up and they're able to be donors right then and there, and you can get point of injury transfusion. So some pretty remarkable advances we saw during these conflicts. A brief aside, so why even talk about whole blood when we have our current technology for blood banking? In certain scenarios, I think component therapy is great in trauma patients, especially ones that are not as severely injured. But if you were to combine all the components to equal what you get in one unit of whole blood, you get a bag with a hematocrit of 29, a platelet count of 80,000. It's going to contribute to your coagulopathy, and it's cold. However, warm, fresh whole blood is exactly what is coming out of the patient, and I would argue is what's needed, especially in these catastrophically injured patients. So this is a helpful slide for me to see that we're not comparing apples and apples when we talk about warm, fresh whole blood and stored components. So this is one case scenario of a casualty. So this is a ranger. So in a Ranger battalion in Afghanistan, he had a blast injury and 2 traumatic amputations and a penetrating torso injury. At the point of injury, he received a total of, this slide is not the greatest. I took a picture of a slide, but at point of injury, because of this low titer O program, he received 6 units of warm, fresh whole blood. He then received further units of cold stored whole blood on the evacuation platform, so the evacuation helicopter, and then continued to receive whole blood, followed by guided component therapy at the Combat Support Hospital, so that this patient, by the time he left theater in Afghanistan, he had received 189 units total of blood products, 60 of which were whole blood, which just illustrates our ability to push transfusion science forward on the battlefield, our ability to use warm, fresh whole blood in these situations. So that's a little bit of an historical perspective that just shows how we kind of had to forget everything we knew and relearn it again to get to where we are today with transfusion science and trauma. We've safely used over 10,000, I think now the number is 12,000 units of whole blood during Iraq and Afghanistan and some of the other associated conflicts, with very minimal numbers of complications. I believe they're in our top Army transfusion scientists talked about the numbers are in the range of 1 graft versus host reaction and a couple of hepatitis, viral hepatitis cases as far as transfusion related severe reactions. So if I were in a situation that was quite austere and the infrastructure where I was located, there were significant issues with, and I was a trauma surgeon, what would I want the capability to do? And I don't know the situation around the world and what everybody has. But if I had everything that I wanted, I would want the ability to use type O whole blood. And I didn't talk about this specifically that much. I didn't talk about it that well, but why is there a difference between the use of type O and type specific? I think I understood this to be a simple, well, type specific is better, right? And that's not the case. Type O was the first type of blood safely used and was used throughout World War II, most of the blood products in Korea, and then a lot of the blood used in Vietnam until we ran short of supplies. The reason that is important is because if it's safely typed, if the blood is it's correctly typed as type O, the risk of a hemolytic transfusion cross-match reaction is 0. And those are the most devastating transfusion-related complications we see. And it's usually in a hectic situation where you have mass casualties and you have an administrative error, so that in a type-specific transfusion, you give a patient the wrong blood type. And it's just a mix-up. It's an administrative mix-up seen in the fog of war. That's why I like type O. So I'm not worried about getting the donor type, I'm not worried about getting the casualty's blood type. I'm just worried about getting my type O donor and getting their blood into the patient. That's why I personally like type O. And I've been involved with walking blood banks that use type specific and type O. So it eliminates that problem. The problem is there were several case reports in World War II where we had minor hemolytic reactions. Now, these did not result in morbidity or mortality, but they noticed that levels of bilirubin were elevated. But minor hemolytic transfusion reactions were noted, and those patients had high antibody titers, so anti-A, anti-B antibody titers. And so the recommendation was pushed forward that low titer only would be used. Since that time, including as recently as the early teens, 2012-13 in Afghanistan, out of necessity, we've used type O non-titered whole blood safely without complication. So if I had everything my way, I would want the ability to do antibody titers, which if you have a built-up infrastructure and you have lab capabilities, that can be done by your lab specialist. However, if you have reagents, like I've had in certain situations, so these reagents, as you see here in this picture, these are the ones you mix with the blood from the donor, and you can do manual titers. It's a grading scale, basically, and you look at how much agglutination you have as you serially dilute the blood from the donor. So if you have the ability to get a reagent, you can do manual titers. But in a pinch, I would take, if I'm dying and I have a type O donor in my unit, I will take that type O blood. That's going to be the type I prefer. Why, again, to be repetitive, the use of type O eliminates the risk of a transfusion cross-match reaction if it's correctly typed. If I don't have the ability to do type O, let's say that I'm not able to successfully do antibody titers, or that's deemed unsafe to use type O without doing antibody titers, I would use a type specific. With type specific, you have to be meticulous about typing both the casualty and the donor. In the US, our military personnel wear dog tags. We found some studies say between 4 and 11% of the dog tags can be incorrect, but we've got plenty of papers out there that have talked about using dog tags to identify and correctly transfuse blood products. But that's always a risk that you've had some type of administrative error when printing off the dog, from going to the lab to the dog tag. How to mitigate that? You can test your unit's blood, your personnel prior to deployment. You can test when you get downrange. These tests take a long time if you have to send them back to a lab. You can test locally if you have that capability. And then you can also use point of care tests. And specifically, we have what's called the Eldon cards. That's a point of care test that's rapid, takes a couple of minutes, and is easy to teach and do. So I would want to be able to test those casualties. I would want to be able to test my donor pool. Another important thing about testing your donor pool is you want to identify people that are higher risk and get them out of the pool, higher risk for transfusion transmissible diseases. Ideally, you do formal testing for HIV, viral hepatitis, syphilis, malaria, those kind of things. If you don't have that, and if you have the necessity of getting blood, that's why we have our screening questionnaires for blood donors to ask about things like recent IV drug use, sex workers, obtaining tattoos, and men who have sex with men. These are risk factors that can temporarily or permanently eliminate you from the donor pool. So a questionnaire can be helpful to minimize the risk if you don't have formal testing. In addition, we do have point of care tests for things like malaria and viral diseases that are transfusion transmissible. And you want to try to obtain a baseline hemoglobin so that you don't have previously undisclosed hemoglobin anemia in your donors. I would want to know who needs this product. So assuming that there's some type of infrastructure for modern blood banking technology, not every trauma patient needs whole blood. So there are some scoring systems that have been developed to determine who needs a massive transfusion. There's a spectrum of what massive transfusion means. It can mean 10 units of blood product in 24 hours. It can mean 5 units in 4 hours. There's all kinds, it's all over the map, but somebody who is predicted to need a lot of blood product to survive their trauma is important. And I'll go over a couple of these scoring systems. If you don't have platelets available and you think that patient's going to need platelets, whole blood is helpful. If component therapy is not working, i.e. the patient's getting cold, the coagulation factors that are low in the components are causing that patient's coagulopathy not to get better or to get worse. In addition, if you just feel like that's what the patient needs because of the severity of injury. So these are a couple of scoring systems that you can rely on to predict who's going to need a massive transfusion. There's TASH score, the ABC score. Some of these are fairly easy data points to get: systolic blood pressure, heart rate. Base deficit or base excess requires some type of lab equipment, and then a fast exam requires ultrasound. And depending on how austere you are, you may or may not have these capabilities. A lot of patients, you're going to know it if you see it. So these are bilateral lower extremity traumatic amputations you can see in certain combat situations with dismounted blast injuries. These patients are going to need a lot of blood product because of exsanguinating hemorrhage. These also have penetrating torso injuries, potentially with solid organ injuries like liver. They can have blast injury to the pelvis with open book pelvic fractures. These patients need a lot of blood products, and they're going to benefit the most from the use of whole blood. Another example, penetrating torso trauma. This patient had a laparotomy, thoracotomy, and bilateral traumatic lower extremity amputations. These are casualties that are going to most benefit from the use of whole blood. What else would I want? I want the ability to have a donor pool that I've identified prior to receiving casualties. I want the ability to notify them that I need them quickly and get them there to start collecting blood. You'll need somebody for crowd control, because it can get pretty hectic. A lot of times, it's the opposite of what you can imagine. A lot of times when you send up the alarm for the need for a walking blood bank, you're inundated. You have too many people show up to donate blood. So crowd control is important. You want to make sure if you're doing type specific, you identify the correct donor and patient types. A lot of times we'll re-verify this using the point of care tests like the Eldon cards. In certain situations I've been in, you can have some heat casualties or vagal episodes with the donor. So you want a place that's cool, relaxed. Sometimes patients or the donors should be laid supine to prevent vagal incidents, vomiting, things like that are not uncommon. And you want to make sure you have checks and balances in place for safe transfusion. There's an administrative piece to transfusion in trauma. So you need people to label the bags. You want to make sure your donors are safely and correctly labeled. The runners or escorts that carry the blood products to and from the donor to the casualty, there's not any mix-ups. And I can't emphasize enough how rehearsal is important in these situations if you don't do this frequently. These are just some examples of walking blood banks where warm, fresh, whole blood is collected from host nation military casualties. Like I said, this is a room full of donors that eagerly showed up when the time was needed. These guys were sitting up, and about 25% of these donors had a vagal episode where they either became syncopal or vomited and required a little bit of care. There's a scale at the top. So there are different products out there on the market to collect whole blood. Some are easy to measure. The bag, you simply fill the bag to a line. Some require you to weigh them, and there's a weight range that you reach. And then you can also cut a piece of parachute cord or string and measure the circumference of the bag and reach a certain amount to fill. Those things are a little bit outside the scope of this talk, but I'm happy to field any questions either during the talk or via email, which I've included at the end, just to talk about my experience. The point being that if you put too much blood in a citrated blood bag, you're not going to have enough anticoagulant so you can fibrinate the blood. If you have too little blood in there, the blood can have too much citrate and there can be an anticoagulant component or hypocalcemia. This is a station set up during these walking blood banks where we do point of care disease testing and point of care blood typing. These are the Eldon cards I mentioned to the bottom right of this slide. These take a couple of minutes to do, are very reliable, easy to teach non-medical personnel to do. And the point of care test for malaria and the viral hepatitis and HIV, very easy to do and very rapid. 2 to 5 minutes, you have a result. Just a few things to be repetitive. You want to safely mark your donor. You want to safely mark the collected blood, safely mark what type the casualty is if you're doing type specific. You want to monitor your casualty, and this is going to be up to your anesthesiologist or your resuscitation personnel. You want to monitor for transfusion reactions such as hemolytic transfusion reaction. In your conscious patient, that looks like back pain, rhabdo or myoglobinuria, hypotension, and these can be rapidly fatal if not stopped quickly. Treat transfusion reaction, which typically involves stopping the transfusion. And then you want to know when to stop. So this is a very precious resource, especially if your donors are from your personnel that are involved in the fight, whether it's hospital personnel or your combat units co-located with you. They aren't easily expendable. A lot of reports talk about using minimally or walking wounded casualties that are co-located as donors. And you want to monitor your casualty that you're transfusing for markers of resuscitation adequacy, like tissue perfusion, coagulopathy. And once the initial severe phase of resuscitation is complete, then you can use a more component-guided resuscitation or transfusion approach. So in summary, if you're going to field a walking blood bank, A few things to keep in mind: know what type you're going to do. Are you going to do type specific? Are you going to do type O, or a combination thereof? Know who your donors are going to be, identify them, screen them, whether that's by questionnaire or ideally with transfusion transmissible disease testing, such as syphilis, malaria, HIV, and viral hepatitis. I would develop and rehearse a plan to notify and collect whole blood from your donors. Develop an algorithm for which casualties are going to need whole blood and when to activate your walking blood bank. Keep track of your donor pool frequently. Combat or war zone is a very dynamic situation, and the people that are in your area change frequently, whether that's by attrition due to the conflict or just movement of people in and out of a certain area. A lot of times, and this was my experience in a couple of deployments, a lot of times you're going to be the expert in your area and be heavily relied upon for a transfusion plan. So that's going to be somebody's area of expertise. They're going to have to be the go-to or point person on. That person should review the outcomes and look for ways to improve the process. And especially when you're getting started, rehearsing that plan and putting it in motion is vital.